Hello, my name's Kath. I'm a trainee advanced clinical practitioner in a couple of emergency departments in the north of England, paramedic by trade. Welcome to my monthly read through of the Emergency Medicine Journal. I read it so you can pretend you have. So this month we are reading the February 2025 issue. It's now May. Life's hectic, please forgive me. I'm hoping to catch up, but it might be that I retire first. So let's get into it. Let's start off. Headline piece is a systematic review looking at reporting of ED clinical trials. Are those results broken down by gender? And if not, what does this mean? So, quick refresh. Sex and gender are being used interchangeably here, basically to mean men and women. If we're going to get down to it, then sex is like your biological characteristics, hormone levels, your genitalia, things like that. In theory, ideally, people want it to be a neat binary. It's not actually if you get into endocrinology, but fundamentally it's kind of like when you're a baby, they have a look at you, decide are you male or female. Gender being all the stuff that's layered on top, all the kind of socially constructed stuff. Women have long hair, men have short hair. Men do emergency medicine, women do GP. So those things are different, and your mileage may vary with all of it, but we'll use them interchangeably in this context. So it's basically saying we know outcomes differ for men and women, and we know that women are underrepresented in urgent care RCTs, randomised controlled trials, and also in the research teams that conduct them. So if we know that there are outcome disparities based on gender or sex, whatever, what is the data and how can we use that to understand why? So this is a systematic review by Aston Chamberlain et al., who looks like they're from London. So they looked at 24 interventional trials in UK emergency departments between 2010 and 2023. And they said how many of those got the results and then presented them broken down by gender. Like this was the results for women, this was the results for men. And they found that only one did. So basically this data is like not being presented, which means we don't have anything to get our teeth into in terms of working out recognising difference in outcomes, and then also, I guess, trying to trace back to what is causing those. So there's evidence gaps, basically. To cut a long story short, this is now an EMJ requirement. So if you're going to get published in the EMJ, you need to break down your results by gender. And I suppose another takeaway is like understand that there's an evidence gap, but then also like be aware of other evidence gaps. I think it's really helpful when we're thinking about about our care in general, but in terms of understanding who's getting missed, whether that's in terms of medication decisions or recognising symptoms. It's just worth being aware of that. Classic one is pregnant women, breastfeeding women. Basically no research happens on those two groups of people. Older patients are often excluded, people with dementia. Homeless patients is the one I bang on about. There's a massive evidence gap for homeless patients. Transgender patients experience evidence gaps. And then, of course, the one we all know, and that's why we're here, is pre-hospital. The pre-hospital arena, I think, is underserved, and there's pretty much always an evidence gap. I feel like every essay I've ever written has been like, well, as usual, there's a pre-hospital evidence gap. And like some of these are kind of understandable. Like I do get why people don't want to try out new drugs on pregnant people. And also it's difficult to do research in the pre-hospital environment compared to an ED. I think we can aspire to achieve better and fill in these gaps, but I think also it's just worth understanding where the gaps are, in terms of understanding the knowledge. You can go learn about stuff, but actually if that knowledge is only based on a small section or a non-representative section of society, then that's useful to know, isn't it? So that's that one. We are going to talk a little bit more. In fact, let me jump ahead. So there's a little bit about lateral flow tests, but I'm going to come back to that and talk about sex differences in the intention and decision to use EMS for ACS, acute coronary syndrome symptoms in Australia, retrospective study. So the background of this is we know there's sex-based disparities in ACS presentations and women have worse outcomes. I don't know about you, I certainly got taught at paramedic school 15 years ago. Cardiac chest pain is a crushing central chest pain, sense of impending doom, diaphoretic, maybe radiating to the left arm, left jaw. That's your ACS. You want to be doing an ECG, aspirin GTN, get to hospital, fine. And it feels like actually only probably in the last 10 years has there been discussion of like, that's actually not always how it presents, and it's particularly not always how it presents for women. And I think when it was first talked about, it was a bit like, oh, women can present with like really weird kind of symptoms instead of like normal ACS pain. And I think as that's evolved, it's a bit like what we're calling like classic ACS pain is actually maybe like the male presentation of it. So it's less that women are weird and more that women's symptoms haven't really been recognised probably until now. And if we're not recognising ACS and acting with according haste pre-hospitally, that's going to worsen outcomes, and same in ED if that's being missed again. So women have worse outcomes when it comes to ACS. Certainly in Australia, I don't actually know what the data is for that. It's just the background of this paper, which is Australian. They attribute it to waiting longer, whether that's waiting longer in hospital or to seek care, I'm actually not sure. And divergent symptoms, they said, yeah, if you are on it and you call EMS if you have ACS symptoms, then you have reduced time to treatment, which we can presume will lead to better outcomes. So they did a cross-sectional study. So there's two parts to this. First was a survey of men and women, and the second was looking at hospital data. So the survey, they basically were like, if you thought you were having a heart attack, whatever that means to you, would you call an ambulance? And the results of that were fewer men than women expressed an intention to call EMS if experiencing ACS symptoms. So 62, nearly 63% of men said they would call an ambulance versus 70% of women. I guess my first thought is, can that remaining 37% of men and 30% of women please just call an ambulance? You've paid your taxes, just call an ambulance. So men less likely to call an ambulance, or stating that they would be less likely, and then they back that up. Let's look at the hospital data and see what the reality is, and they found the hospital data said that men were less likely than women to present to ED via EMS. Okay, fine. But actually, things to take away is there's loads of heterogeneity within sexes. So yeah, this, and I guess this is we're thinking as well in terms of like EMJ now needing all results to be broken down by sex, is that like those are pretty much the like is pretty much the most simplistic way of dividing up people, and actually within those two groups there is so much diversity. So they broke this down further and looked at like men and women. Looking in further, then we've got things like different outcomes for people who speak English as a second language, people who had cardiovascular risk factors, people who had no health insurance in Australia or unclear insurance, people of Aboriginal or Torres Strait Islander origin, people that were born overseas. So there was actually loads and loads of variables that were much more detailed than just men or women. So our takeaways are there's diversity within those groups. Education can be targeted using that data, and also just that we need to make sure we're educating healthcare providers about the different ways that ACS symptoms, different ways that ACS can present in people. Back to some lateral flow tests. Let's go back to the glory days of COVID. I think this is an interesting one because, well, basically, let me explain it for you. So it's UK-based multiplex lateral flow test sensitivity and specificity in detecting influenza A, B, and SARS-CoV-2 in adult patients in a UK emergency department. Okay. So they were looking at, so lateral flows being the ones we all remember from COVID, you're doing before a shift, and it gives you a pretty much instant result, which is really helpful for ED. And then they compared that with the ones that you do and then you send off to the laboratory, which is the PCR testing. That's the latter being used as the kind of gold standard of accuracy for a test. Lateral flows we know are less reliable. This is looking at exactly like how reliable they are and using the ideas of sensitivity and specificity to quantify that. I'm going to try that again. Let me try and explain sensitivity and specificity in a way that you can understand and I can understand. So They do both do what they say on the tin. Sensitivity is about how sensitive a test is. So imagine we have 100 people that have measles. We do a certain test on them, and sensitivity is about how many of those positives do we pick up with the test. So the percentage of true positives. So say we have a test for measles. We test all of them. We get 100 positive tests. Great. This is a very, very sensitive test. It's picking up all the positives. There's no false negatives. If you have a test that picks up 50 of the patients as measles positive, but misses the measles in the other 50, then that's 50% sensitivity. And so obviously we would love a 100% sensitive test. It's just very difficult to get that. So some tests are more sensitive than others. So amylase in pancreatitis is a very sensitive test. So we can be reassured that if that's negative, that we can be quite confident in saying it's not pancreatitis if you've got a negative amylase. And I guess the crux of this is about understanding how much to trust tests, how to use them, how to be thoughtful about using them. So we've got sensitivity on one hand. How likely is this test to pick up a positive if it's there? And then specificity, again, as it says on the tin, is about how specific a test is. So this is, so say you have, this is about the percentage of people who test negative and who don't have the disease. So it's about false positives. So say you have 100 people, 50% of them have measles, 50% of them don't. You test them all and you get 70 positive results. There's false positives going on there. So it's, I guess, giving you confidence in whether your test can give you true negatives or not. And so tests with low specificity throw up lots of false positives. They would be things like D-dimer and CRP, and the kind of tests that they can ping a positive, but you're not like, right, positive D-dimer, it must be a DVT, which is the one you classically use it to test for. It's more like, right, we've got this positive, now we maybe need to investigate further, because there's basically lots of other things that can ping a positive D-dimer, and there's lots and lots of reasons you can have a raised CRP. Which is why you see a big part of ED is agonising about whether to do D-dimers or not, and people hate it if people are just doing D-dimers on everyone, because you get all these false positives, and that leads to over-investigation, over-treatment, which is then how you get part of your decision-making becomes about whether to do a test or not. It's not that you just do like every blood test ever, and then let's just look at the results, because actually the results aren't that helpful. So that's how you get things like the Wells score for working out whether to even do a D-dimer on a patient. Or your PERC score rather. So that's specificity and sensitivity. It's really helpful to understand those two things in terms of deciding whether to do tests and also interpreting the results. I hope that makes sense, because it took me a couple of times trying to explain it. So in this study in particular, they're looking at the sensitivity and specificity of lateral flow testing. So in the lateral flow testing available in EDs is for flu A, flu B and COVID. And the main thing they're looking at is sensitivity rather than specificity. So results vary. So flu A sensitivity is 67%. Flu B sensitivity, is 94%, and COVID is 48%. So that is telling us about false negatives. So if you have flu B, it's very, very likely to get picked up on. 94 out of 100 that came back positive from the lab testing had also come back positive in the lateral flow testing, whereas 48%, so half basically of COVID. So of say they got 100 back from the labs that were COVID positive, only half of them had actually tested positive in the department under lateral flow. So what this is saying, and I know the flu strains vary yearly, but in these tests, if you get a negative flu B lateral flow, that's reassuring that they probably aren't then going to go on to test positive in a laboratory PCR test. Whereas if you get a negative COVID test, actually it might well go on to then test positive in the laboratory. So it's telling you how much to trust each test, basically. Of course, you're always looking at the patient as well. So there's lots of false negatives. And then they looked into it a little bit further, and they feel like the false negative, is because there is usually a lower viral load, a smaller viral load. So that's why it's false negative. It's not just totally random. So it might well be that if they're tested a few days later, that they then ping a positive. So false positives unlikely in these tests. False negatives are likely, especially in flu A and particularly in the COVID testing. So very helpful in an ED, and very helpful when we're thinking about what we're actually trying to find out with testing and how much to trust the results. So the greater the viral load, the greater the sensitivity of lateral flow testing is the takeaway. Thank you for coming with me on that journey. Right, what's next? Are there differences in low acuity ED visits between culturally and linguistically diverse migrants and people with English-speaking backgrounds? A population-based linkage study of adults over 45. So this is Australian as well. So comparing people coming to ED who are either born in Australia, English as a first language, or an English-speaking migrant to Australia, like all the doctors and healthcare staff that have left the NHS and are now running the Australian healthcare system, as far as I can tell. So they're kind of lumped in together in that we're going to presume that if I moved to Australia, I would have a pretty easy time of it in terms of speaking the language, knowing how to navigate the systems, and having relatively few barriers to accessing healthcare, compared with people that don't speak English as a foreign language, don't speak English as a first language. So the background for this is fairly globally, we've got increasing ED visits with low acuity problems. And they got the data from this for a cross-sectional survey of 45-year-olds and older. So there's a study going on in Australia called the 45 and Up study, which is a really huge study. It's like a cohort study, surveying people's health experiences for a really long period of time with loads and loads of people, which just means there's like a really data-rich setting you can pull stuff out of. So this is the data set that they were accessing. So on one side we're comparing culturally and linguistically diverse people with English-speaking people, or people who speak English as a first language. And I guess the question is there more low acuity visits from people who don't speak English as a first language? So in 2023, there was a voter survey in Australia, and 90% of people agreed with the statement, we don't need more people because our hospitals are overcrowded. So that's the background, really, is there's a public perception that people who are migrants to Australia are overusing ED, are overcrowding the ED. And this paper is looking into whether that's actually true. What did they find? They said culturally and linguistically diverse people had the lowest rates of low acuity ED visits. If they had arrived in the last 20 years, they had 28% less low acuity ED visits, and if it was greater than 20 years, they'd had 9% less. So culturally and linguistically diverse people are not overusing the ED for low acuity issues compared to the general population. Takeaways, is this transferable? So in Australia, 40 to 60% of ED visits are semi or non-urgent, whereas in the UK it's 17. So it can feel frustrating in the ED and pre-hospitally sometimes in terms of things that aren't an emergency, which is why on the side of ambulances, just like 999 is only for your heart has stopped, your head has been cut off, your legs have been cut off, the end, and then actually everyone's still calling with sore fingers and stuff. Fine. But actually it's like twice or three times as bad in Australia. So why this is, I don't know loads about the Australian system. I know that they don't have universal healthcare in the same way, because in the previous study we saw about ACS symptoms, people were talking about not having insurance or having unclear insurance status. So that can be a barrier to care. And if people are undocumented, so don't have official documentation of their legal status, i.e. here illegally, I don't really like that term, but basically if you don't have papers, people end up avoiding places where you might need papers. I know that people can avoid ED and avoid healthcare in this country if they don't have papers, which means they can be undertreated and not be able to access care. So I guess, is everyone getting to ED that wants to come to ED? Is everyone able to get a primary care appointment that wants a primary care appointment? I would be interested to see a similar study in the UK, particularly because this is the kind of thing that Reform get elected on, these perceptions. And it's very frustrating when the EDs I work in, international staff are absolutely the backbone of those EDs. And if everyone who spoke English as a second language didn't come to work, the entire hospital would crumble on that same day. So it is frustrating to see those misconceptions. And it would be interesting to have the data to actually get into it. Now then, is it time to reframe resuscitation in trauma? This is by Carden and Horner. It's an opinion piece by 2 crit care doctors, and it's about adding nuance to management of bleeding trauma patients. I have not managed to say nuance so far, but now I will not stop. Before I start, there is a whole blog piece about this on the St Emlyn's blog, which is really good for pre-hospital emergency medicine. That is written by Simon Carley, who's an ED consultant and does HEMS as well. So that piece is called "Is Diastolic Blood Pressure the New Resuscitation Target?" It looks at this paper, and it also looks at broader discussions and goes into much more depth than I'm going to. So I'd fully recommend everyone read it. I mean, watch the rest of this, but then go there and read that. And read that blog in general. If it's not already on your radar, it should be. So back to this. It's just a short one. It's just 2 pages. It's an opinion piece. Basically saying, right, one of the kind of cornerstones of trauma resus is permissive hypertension. The idea that we're going to accept hypertension in a way that we wouldn't in your average patient. And the idea of this is, on one hand, we're trying to maintain some kind of BP in order to preserve cerebral and cardiac perfusion, but then we are also balancing the perceived risk of blowing off clots. So we know that they're someone that's been bleeding a lot. They've managed to clot a little bit, and now we want to preserve those clots, so we don't want the BP to be too high and blow all them off. This is saying, actually, we should be thinking more about diastolic BP. So diastolic blood pressure, so that is the blood pressure when the heart is relaxing, is really important for coronary perfusion, because coronary perfusion occurs during diastole. So during systole, which is when your heart muscles are contracting and squeezing, all the coronary blood vessels supplying blood to your heart are constricted during this, so they fill with blood when the heart relaxes. So diastolic blood pressure is really important for coronary perfusion, and if we have a really, really low diastolic blood pressure, then we're going to get really, really low coronary perfusion. So I've heard the crit care guys talking about this, that if you can get your diastolic up during cardiac arrest, ALS, then you're feeling more confident about getting ROSC. And if you get a decent diastolic post-ROSC, then that is also encouraging in terms of outcomes. So this opinion piece is basically expanding that to say, like, during traumatic resus and care of bleeding patients, we need to be thinking about diastolic BP. So fine. Oh, the other thing it said, I don't think I transferred across in these notes, is that the idea that if your blood pressure is too high, you're somehow going to like pop out clots that are formed like a kind of champagne cork is overly simplistic, and it's guided as it's one of those ideas that kind of makes sense on paper but isn't really how it works. Like, actually, if you've got some big hemorrhage, your body's response is more complicated than that. It's not just that you get a clot kind of bunging up an artery. You also get kind of like localized vasoconstriction and other changes. So it's kind of saying we need to be a little bit more nuanced. That's not totally how it works. It's not that if your blood pressure gets above a certain systolic level that suddenly all these clots will pop off like champagne corks. So that permissive hypertension makes loads of sense on paper, but actually the reality is a bit more complicated, and in reality we need to be paying a little bit more attention to diastole or diastolic BP. Right, nearly done. We've got 2 more things. The next one is point of care ultrasound for foreign bodies. which I guess is exciting news for the ultrasound bros of ED, of which there are many, in that there is something new for us to scan. So someone presented to ED with a 3.5 centimetre spine from a plant in his leg, which is I mean, that's quite big, isn't it? Here it is next to a measuring tape. It's massive, and I mean, I like my gardening, so I'm really keen to know actually what kind of plant it was for interest. But they don't document that. Apparently, that's not important. Basically, yeah, massive spine. I'm presuming it was in the UK, so I really would like to know what it was. Oh, hang on. University of California. So I take it some American plant with massive spines. Guys walked into it. He's got a puncture wound, but he's pretty sure that he's got a huge spine into his leg. The problem here is, so if you thought you have a bit of metal in you or a bit of glass, go to X-ray, fine, you can see it really crystal clear on the X-rays because they are radio opaque. The problem with wood, it is radiolucent. Is that a word? The opposite of radio opaque? Yeah, radiolucent. I didn't just make that up. So wood's radiolucent. So what we're going to do to find this spine? Well, the answer is ultrasound. So you can scan at the bedside, and it turns out. So wood is only visible on 7 to 15% of X-rays, so really unhelpful to do an X-ray in this situation. Whereas they did a meta-analysis of ultrasound studies and it's visible in 72%, so much more likely to be seen on ultrasound than X-rays. So that's good to know. The other thing is on a cadaveric study, there was 92% specificity, and we know all about specificity now, which is great. What this is telling me is that there is a study out there. I haven't gone and looked it up, but there's a study out there where they're sticking bits of wood into dead bodies and then scanning them with ultrasound. I mean, fine, if you thought you had a weird day at work, someone out there had a weirder one. The other thing I liked about this, which is not really useful from a pre-hospital perspective, but it's kind of interesting, is that say you have a possible wood foreign body somewhere weird in your hand or your finger, it's really hard to scan because you can't get the contact with a curved surface. It's a lot easier to scan somewhere flat. They said you can put the bit that you need in a water bath, and then you can scan and use the water for the so basically I want an opportunity for someone to come in with a spike in their foot, and I want to get a water bath and get an ultrasound machine and just have the best time. Right, last one. Journal update from the New England Journal of Medicine. So this is useful pre-hospitally. IO, or intravenous vascular access for out-of-hospital cardiac arrest. They compared. So it's in the New England Journal of Medicine, but actually it was in Denmark. It's an RCT in Denmark comparing IOs versus IVs and out-of-hospital cardiac arrest. I'm going to summarise really quickly. There was no difference in outcomes. There was potential bias. And also, there's no evidence base for adrenaline anyway. So that was quick, wasn't it? Right, this was quicker than usual, and I'm going to edit out all my chats about sensitivity and specificity except the one that made a little bit of sense, so it will even be shorter than half an hour. So thank you very much for watching. I will see you next month, aka whenever I get around to writing up March 2025. Thank you so much for watching, and I would love to hear your opinions about any of this stuff, so just drop me a comment and I'll see you next time.